Welcome to Chronic Obstructive Pulmonary Disease Part 2. We had discussed up to investigation in Part 1. I would recommend everyone to go through it first before following this lecture. We shall go through classification, both the MRC and GOLD classification of COPD patients, discuss the treatment options both for chronic stable phase and the acute exacerbation phase, and discuss few clinical questions. First, the modified MRC dyspnea scale. MRC stands for Medical Research Council. It is the most used guideline in UK. It is often used in combination with other classification scales to grade a patient. Now, MRC grades patient based on the degree of breathlessness related to activity. It's from grade 0 to 4, as you see in this box. The 0 is no breathlessness except when the patient isn't doing a strenuous exercise. Grade 1 is when the patient is hurrying. Breathlessness comes when he or she is hurrying on the level or a slight hill. Grade 2, the patient has to walk slower than his age group people or even on the level ground, or has to stop while walking at own pace. Grade 3 is the patient requires frequent stops for breath, for example after walking for 100 meter or a few minutes even on the level ground. Grade 4, the patient is too breathless to leave the house, or even smaller activities like dressing or undressing can cause breathlessness. Now let's examine the GOLD classification. GOLD stands for Global Initiative for COPD. GOLD classification is used worldwide with slight modifications from country to country, but it stages the patient depending on spirometry values from 1 to 4, and severity of the disease is from mild to moderate, severe and very severe. We know that FEV1 over FVC less than 0.7 is the diagnostic factor for COPD. Now, FEV1 ratio determines whether the patient is mild, moderate, severe or very severe. In mild cases, FEV1 is above 80% of that predicted. Moderate patients, the ratio of FEV1 over FVC is less than 0.7, but FEV1 is reduced. It is less than 80% but more than 50%. So, it is between 50% and 80%. For severe cases, FEV1 is further reduced. It is between 30% up to 50%. And in very severe cases, the FEV1 is less than 30% of that predicted. Now, after grading these COPD patients, let's see how do we treat these patients. First, a few general steps. Smoking cessation comes first and foremost, as it is the most common cause of COPD. Second will be medical treatment with mucolytics for cough, flu and pneumococcal vaccinations, and we shall later discuss bronchodilators in detail. Most of these patients are in reduced both physically and activity level, so pulmonary rehabilitation with focus on diet advice, supplements and exercise is recommended. And all these disabilities causes severe but treatable depression. Before we go into more specific treatments, we shall discuss each aspect a bit in detail. For example, long-term oxygen therapy is one of the disputed treatments of COPD patients, but most recommended and clinically shown to increase even survival years. Let's go through the UK NICE guidelines to determine which patients among COPD cases can receive long-term oxygen therapy. They must come under one of these three groups. First, the non-smokers or the patients who have stopped smoking and are clinically stable with a low oxygen under 55 millimeters of mercury despite maximal treatment, and these low oxygen values are stable on 2 occasions measured 3 weeks apart. The next set of patients are patients who have a better PaO2 than the first group, between 7.3 to 8 kilopascal units, but they have complications like pulmonary hypertension or have developed secondary polycythemia, or we see peripheral edema in this patient, or nocturnal hypoxia. They can benefit of long-term oxygen therapy. Now, the third group of patients are those who are terminally ill. They may have effect of oxygen through nasal catheter to alleviate the symptoms of breathlessness. Now, an important part of COPD treatment is bronchodilators. Let's dive into a few details here. The two groups of bronchodilators used are beta-2 agonists and anticholinergics. Anticholinergics are also referred to as muscarinic antagonists. They are short-acting or long-acting. So we can in a short form call them SABA, LABA for beta-2 agonists, SAMA, LAMA for anticholinergics. They act on two different receptors. Beta-2 agonists acts on beta-2 receptors, while anticholinergics acts on M3 or muscarinic receptors. Though the mechanism of action is different in these two group of medications, they act by preventing smooth muscle contraction, or they aid in smooth muscle relaxation, thus opening the bronchioles and holding the airways open. Examples of SABA: albuterol, LABA, formoterol or salmeterol. Example of SAMA is ipratropium, and example of LAMA is tiotropium. In mild to intermediate cases, a combination of SAMA and SABA is used. Moderate to severe case of COPD, where the FEV1 is often less than 60%, a long-acting bronchodilator, either LAMA or LABA, or a combination of LAMA and LABA is used. These can be given either as nebulized form or through a metered dose inhaler. Now, other bronchodilators are inhaled corticosteroids. They are given in combination with LABA in severe cases. They act by inhibiting cytokines, which further activates the migration of WBCs and thus reducing inflammation. The third line of treatment are PDE inhibitors or phosphodiesterase inhibitors, but they are carefully used because of possible side effects. Theophylline, for example, is used for giving patient a diaphragmatic rest in very severe cases, and a newer drug is roflumilast, which is a selective PDE4 inhibitor. Before we explain the treatment of acute exacerbation in COPD patients, it is important to get a clear idea of which bronchodilator to choose for which patients when they are chronically stable or when they worsen. So this picture is meant to explain that concept and taken from Harrison textbook of internal medicine. It considers two factors: exacerbation episodes happening in a year and how grave are the symptoms or how severe are the symptoms. The severity of symptoms are based on the MRC scale. So the first row is for high-risk patients where they have exacerbations more than once or twice in a year, which requires hospital admission. The low-risk category has had 0 or 1 exacerbation history in a year, but without hospital admission. Let's examine group A. These are low-risk patients and with low symptoms based on MRC scale. So we can try a bronchodilator, often a short-acting depending on symptoms. Evaluate the effect on and see if we need to continue, stop or try another class of bronchodilator. Now see group B. So these patients have low risk, no hospital admission needed in a year, but they have high symptoms based on the MRC scale. The MRC score is often more than 2. So these people, because of high symptoms, require a long-acting bronchodilator, LABA or LAMA, or in combination if the symptoms persist. Now coming to group C. They have low symptoms based on MRC scale, but high risk because of hospital admissions during exacerbation. So they require a LAMA. Muscarinic antagonists are individually chosen if we have to choose between these two categories. And if these patients have further exacerbation, we can try a combination of LAMA and LABA or LABA with inhaled corticosteroid. Now coming to group D, who are both high-risk patients and have high symptoms based on MRC scale. They require long-acting bronchodilators, either LAMA alone or further LAMA and LABA combination or LABA plus inhaled corticosteroid. In case of further exacerbations, we have to try a combination of 3: LAMA, LABA and inhaled corticosteroid. But if these patients have further exacerbations or persistent symptoms, we have to consider giving them phosphodiesterase inhibitors or macrolide to reduce the inflammation in the airways. So hope this is clear now. Now let's see the treatment for acute exacerbation of COPD patients who require hospital admission. Oxygen therapy is the first and foremost step but has to be assessed with an arterial blood gas analysis. It is recommended to give controlled oxygen aiming for a lower but acceptable saturation at 88 to 92% for the patient. Do not give high concentration or high flow oxygen because there is risk of respiratory failure or respiratory distress, because it is the low amount of oxygen in blood hypoxemia which stimulates the chemoreceptors in the central nervous system for holding the respiration going. Bronchodilators are often given in nebulized form. It is a combination of short-acting beta-2 agonist and short-acting muscarinic antagonists, in addition to all the permanent medications the patient already is on. Corticosteroids studies show that in acute exacerbations, systemic administration, either oral or IV, is recommended in high dose. For example, prednisolone 30 mg for 5 to 10 days and can be abruptly stopped. Antibiotics in case of infection, often an aminopenicillin or a macrolide is recommended. Follow the specific guidelines according to the country. And if the patient worsens, there is persistent tachypnea and respiratory acidosis, first a non-invasive ventilation is tried, often with a BPAP. But if the patient worsens and there is a reversible cause for deterioration like pneumonia, intubation and ventilation may be needed. If the patient has peripheral edema or fluid retention or heart failure symptoms, diuretics can be used. So that was all about COPD. Now let's try solving two clinical cases to understand COPD better. Okay, here comes the first question. A patient who is known to have COPD is rushed into the casualty or the emergency department with an exacerbation of breathlessness. On examination, she has a GCS of 15, oxygen saturation of 85% on pulse oximetry. Arterial blood gas values are as shown while breathing on 28% oxygen, pH at 7.13, partial pressure of oxygen at 6.9, partial pressure of carbon dioxide at 10.8, bicarbonate at 32. What is the most appropriate treatment? Let's see the options. BiPAP, CPAP, doxapram infusion, endotracheal intubation, high flow oxygen. So first evaluate the patient based on the factors given in the question. GCS of 15 is okay. Oxygen saturation at 85% is low, but it is important to know that some of these patients may have chronically low saturation. But pH, in spite of giving oxygen, shows severe acidosis at 7.13. While partial pressure of oxygen 6.9, when you convert kilopascal into millimeters of mercury, it is around 57. We have to multiply it by a factor of 7.5. Or you can learn the values in kilopascal depending on what is used in your clinical system. Partial pressure of carbon dioxide is at 80 millimeters of mercury, and bicarbonate is increased above normal value to 32 millimoles. So we can easily say that there is a respiratory acidosis in the patient with compensation, metabolic compensation, as bicarbonate is increasing. It shows that it has been a chronic condition because metabolic compensation takes time. The only option we might be a bit confused is this doxapram infusion, which is actually a respiratory stimulant. It acts by stimulating respiratory center in the medulla through peripheral carotid chemoreceptors, but doxapram is often given to reverse the effect of anesthesia, etc. It is very short acting, so it is not recommended in this case, as even on oxygen supply the patient is in severe acidosis. So BiPAP, as we learned earlier, is the most recommended form of non-invasive ventilation as a first step. Now coming to a second case, a 65-year-old man with known COPD treated with inhalers was admitted with a 6-week history of gradually increasing shortness of breath. He was afebrile, mildly confused with a respiratory rate of 26 per minute, and there were no changes in the chest X-ray. Arterial blood gas analysis shows a result of pH with 7.3, partial pressure of oxygen at 7.8, kilopascal, which is around 60 millimeters of mercury. Partial pressure of carbon dioxide at 8.5, which is around 64, which is the most appropriate immediate management in this patient. You're seeing the options here. Let's analyze the condition of the patient first before ruling out option by option. Now we see that the patient has a high respiratory rate and is mildly confused but febrile, so we are not sure about the infections. Neither is chest x-ray showing any changes. But arterial blood gas analysis show mild acidosis and hypoxia, which is very expected. But there is carbon dioxide retention. Carbon dioxide is high. So there is a respiratory acidosis happening here. So the patient will not tolerate high flow oxygen well because it can suppress respiration again. Now coming to the second option, which is IV theophylline. We know that phosphodiesterase inhibitors are often used as second or third line therapy and not as the first management here. IV hydrocortisone, which is the third option. Corticosteroids, as we know, is shown to reduce the length of hospital stay and given in acute exacerbations of COPD, but it is not the immediate management. What about intubation and ventilation? We know that non-invasive ventilation should be tried first in severe cases before we progress to mechanical ventilation or intubation. So we are left with the fifth option, which is nebulized salbutamol and ipratropium, because short-acting bronchodilators, both beta-2 and muscarinic antagonist, are given in combination in nebulized form for this patient. So the option number E is correct. So that was the end of COPD part 2. Thanks for watching.